Hello, everyone. Thank you for joining today's webinar. This is Andy Dwyer with Fight Colorectal Cancer in the University of Colorado Cancer Center, and we're very excited to have you join us today. Just making sure that our audio is good and that everything looks good on the technical side, and it looks like we're good to go this morning. So thank you again for joining us. I want to reintroduce two of our presenters, Lisa Koo and Lisa Axel, who are also colleagues of mine here at the University of Colorado. Both are board-certified genetic counselors, and they actually provided some information for us this fall about collection of family history, information to know about what we should really collect and capture that's relevant to the experience of collecting information and knowing your risk for colorectal cancer. And today they're actually going to spend a little more time really going in to the detail around syndromes related to genetic and familial risk and hereditary syndromes. So I just want to remind everyone today that, of course, we will be sending out an email and materials after to see what you thought of the webinar, the general information, additional questions you might have, as well as giving us some updated information you might want to hear in the future. Just also a quick reminder that a way for you to ask questions is to type those in at the right side of your screen. And then there will also be the Twitter follow and chat that will follow today as well. So please keep that in mind for today's presentation as well as future presentations. Just a quick reminder that one of the products in the program materials that we offer is a guide in the fight, which is our patient resource guide. We're currently drafting the stage 2 guide, but we currently have the stage 3 and 4 late stage guide that is available for online download on our website, and we just are very excited about this. We're getting a lot of fantastic feedback from cancer centers and patients about this guide really helping people through their journey as they're diagnosed with colorectal cancer. A quick nod to also our funding of science and the LISA Fund that really devotes a lot of dollars towards late-stage innovative research for colorectal cancer. We're very, very excited because in the years past you'll notice that our mark range was around $30,000 to $45,000 to $50,000, but this year we're actually offering $100,000 to an investigator for late-stage research because we are so much dedicated to the funding of colorectal cancer research and innovation. So just a reminder that if you're interested in funding science, we're definitely taking donations, but we also are really proud of the work that the scientists and team members have done around the LISA Fund and innovation. Just a quick reminder, of course, that today is to provide it as information. Our aim at Fight Colorectal Cancer is to provide good, detailed information for colorectal cancer survivors, clinicians, as well as family members, but this in no way replaces direct medical care. And, of course, we want to ensure that 911 or any emergency modalities are connected if there is a need for something that's beyond routine care. So just to remember, we don't endorse any specific products, physicians, or products or treatments, but really to impart information to help really advocates and survivors in their journey. So just a fun picture of our two presenters today, again, Lisa Koo and Lisa Axel, and we're very excited to have both of them on and to present with us today. One thing I just wanted to note as well as we get into the presentation is several of us from the Fight Colorectal Cancer team joined the GI ASCO meeting this last couple of weeks and are very excited about being able to provide some summary and detail. And so in February, we're going to be running a webinar that actually summarizes some of the most innovative research and innovation that's coming for cancer survivorship and treatment, and also share a advocate's perspective and talk a little bit of our RATS advocacy training program. So we're really excited about that. I think Heavy will mention a little more about that at the close of our webinar today, but that webinar is slated for February 17th at 1:30 Eastern Time. And so I wanted to give a quick shout to the time and spent over really spending time learning about what's happening on the colorectal cancer research realm. And so, and also a special thanks for Michael and Kevy from our team who have definitely helped, and as well as Danielle with making this webinar series possible for us as well. So with that, the special thanks to Lisa and Lisa, who are both friends of mine and work together here at the University of Colorado Cancer Center. We're very excited to have them today as we continue this discussion about family risk, familial syndromes, and hereditary syndromes. Okay.
All right, well, thank you very much for that beautiful introduction, Andy. I really appreciate it. So this is Lisa Koo, and I'm going to start. So our last presentation we focused on family history taking, and we gave you some ideas on how to assess if your family fits into a particular inherited cancer syndrome. And we asked you to think about what you know about your family history of disease and put all that information together. So I just wanted to quickly review some of the information that we presented last time. So we talked about how to look for important clues in a family history, such as looking to both sides of the family for cancers. Oftentimes people forget that cancer can be inherited from either the mother or the father, especially when talking about gender-related cancers like ovarian or prostate cancer. We talked about looking at least 3 generations to get a better idea of if there's any sort of pattern in the family. As most cancer syndromes are inherited in a dominant fashion, which means you would see a pattern of something being passed down from generation to generation. We discussed looking for specific diagnoses. So for example, if a grandmother died from an abdominal cancer, it would be helpful to know if this were actually colon or uterine or something else. Age of diagnosis is also helpful when thinking about hereditary cancer syndromes. And determining the number of family members without disease is important as well, because a person who has 12 siblings and only 1 with cancer might be looked at completely different compared to someone with no siblings at all. And we talked about questions that you could ask your family members to get more information, such as, did anyone pass away at a younger than average age from cancer? What kind of cancer did they have? Do the same cancers keep appearing in different family members? And then write that information down so that it's documented. And then talk about it with the generations below, your children and your grandchildren. And then finally, we talked about ways to confirm family history information and diagnoses, such as getting written documentation, whether that be with pathology reports, genetic test results, or even death certificates. Basically, anything that helps to confirm that an individual truly had what you think they had is helpful. So aside from family history, we can look at other risk factors for disease, and we can essentially group these into 2 categories. These we have some control over. These same factors appear in study after study, and not surprisingly, we're actually finding that overall a healthy lifestyle decreases risk, even though it still doesn't guarantee that the disease won't happen. And specific to colon cancer, studies are showing that a high intake of red meat and high-fat dairy products, fast foods, and refined grains, etc., increase colon cancer risk, while healthy diets, including lots of fruits and vegetables, whole grain cereals, etc., decreases risk. And we also know that regular exercise, limited alcohol use, and no smoking decreases risk as well. But these risk factors we don't have as much control over. We can't control getting older or what our family history looks like or whether or not we're male or female. But we still use this information to help us figure out how to be proactive with our risk for cancer. So all in all, cancer risk is influenced by a number of different factors, some that we can control and others that we can't. So we just addressed how family history and lifestyle influences cancer risk. And now we're going to talk a little bit more about how certain genes can play a role in inherited cancer risk. So the important message here is that each risk factor doesn't work independently from one another. So when we talk about calculating cancer risk, each of these things need to be accounted for. So now we're going to focus the rest of our talk on the genetic aspect and more specifically on hereditary colon cancer syndromes. So when we look at colorectal cancer as a whole, as you all probably know, most cases are sporadic, meaning we don't really know why it occurred, or maybe it was just random chance. So most of these cases have an older age of onset, and you may have heard that there's a lifetime risk for developing colon cancer, about 5%, or 1 in 20 individuals. So about 10 to 30% of the time we see a familial pattern, meaning that we're seeing more colorectal cancer than we'd expect to see just based on random chance. So instead of just 1 person in a family developing cancer at a later age, we might see 3 or 4 cases. And then these smaller pieces of the pie are representing the hereditary cancer syndromes, at least the ones that we know about today. So Lynch syndrome is the most common of these, and Leeson is going to be talking more about this in greater detail. But I'm going to start by talking about more of the rarer of these syndromes, the polyposis syndromes. So these include familial adenomatous polyposis and then some of the more rare syndromes as well. So to start by talking about the polyposis syndromes, it might be helpful to know a little bit more about the fact that there are actually different types of polyps. And these help us to know which syndromes we might want to consider more closely. So to start are the adenomas. So adenomas are the precancerous types of polyps. These are the ones that have the potential to turn into a malignancy. So about 50% of all individuals will have an adenoma in their lifetime. So it's not alarming to see one or two found on a colonoscopy. However, if these are left for a long period of time, adenomas have the potential to progress to a type that can have a significantly higher cancer risk. So that is why it's really important to remove those polyps for cancer prevention. The next type of colon polyp are called hyperplastic polyps. These are benign polyps. They're very common and usually not of concern unless they're found to be large or large in number, or if they're found in the proximal part of the colon, which is the part of the colon furthest away from the rectum. There's also a few hereditary syndromes that have hyperplastic polyps, MUT-YH-associated polyposis and P10 hamartoma tumor syndrome, and I'm going to talk a little bit about these in a minute. And finally, there's the hamartomas. Hamartomas are also thought to be benign abnormal growths, but more recently it's felt that these polyps also can be a precursor to cancer. So we're learning a little bit more about that. And they can also grow large enough so that they can cause other problems, such as bleeding or obstruction of the colon. So now I'm going to talk about familial adenomatous polyposis, or FAP, which is the most common of the polyposis syndromes. The classic FAP presents with many, many adenomatous polyps, upwards of hundreds to thousands. These, again, are the precancerous types of polyps, so if they're left untreated, then the risk for colorectal cancer is nearly 100%, which is something we rarely say in genetics. The average age of onset of polyp growth is around age 16. But we certainly have seen cases in children as young as 4 or 5 years old. The incidence of FAP is still rare. It's about 1 in 10,000, and FAP is associated with mutations in a gene called APC. This is a picture to demonstrate the extent of the polyp burden that can be seen in individuals with FAP. As you can see, oftentimes the extent is too great to consider doing just polypectomy, which is the removal of the polyps. So in individuals with classic FAP, some form of colectomy will need to be considered at some point in their life. And that's obviously a very difficult discussion that needs to be involved with a gastroenterologist or GI surgeon who's well versed in treating individuals with FAP. So the main features of FAP are the large number of polyps that can occur in various organs along the GI tract, the colon, the duodenum, the small bowel, and the stomach. And subsequently, wherever polyps can grow, there's potential to develop cancer. In addition to those sites, cancer can also develop in the liver, which are called hepatoblastomas, brain tumors, thyroid cancer, and possibly also cancers of the pancreas, bile duct, and adrenal gland. So in addition to colon screening, individuals with FAP may also need to consider additional cancer screening. Some of the other features of FAP include benign tumor growths elsewhere. So desmoids, which are often seen anywhere in the abdominal wall, osteomas, which are bony growths, typically in the jaw or the long bones, extra teeth, CHIRPY, which stands for congenital hypertrophy of the retina pigmented epithelium, which are benign growths in the eye, and then skin tumors, such as the epidermoid cyst that's shown here in this picture. The desmoid tumors are benign growths, but depending on their location, they can actually cause some serious problems in individuals with FAP, and it's often the second leading cause of death in individuals with FAP. So unfortunately, they do commonly recur after surgical removal. So it's really important to consult with a surgeon, again, who's familiar with FAP. Some risk factors include surgery, having a positive family history of desmoids, being female, and the location of where the mutation is along the APC gene. So I'm not going to get into a lengthy explanation about that last point right now, but this is something called genotype-phenotype correlation. And if you're interested in learning more about that, then this is my quick plug just to remind you to consider meeting with a genetic counselor if you want to learn more. So the screening recommendations for FAP include colonoscopy and upper endoscopy starting at a young age, and removal of the polyps or consideration of colectomy when the polyp burden gets to be too great. For desmoids and polyps, Sulindac, which is an NSAID, and tamoxifen are being studied to see if these are effective for reduction of those tumors or polyp size. And these are now actually mentioned in the national guidelines for screening. And so I have a feeling that this is probably going to bring up some questions for many of you. So I'm going to mention right now that I'm not a physician, and if you have more specific questions regarding the use of these drugs, you should talk with your doctor about this. And finally, because of the increased risk for thyroid cancer, then annual ultrasound and thyroid exam should be considered. So on the right side of this table, it's titled AFAP, and that stands for attenuated FAP, which is a milder form of FAP. And as you can see, it has some very similar recommendations for screening, but with later ages of onset and less frequency. And this is because we see actually a later age of onset of colorectal cancer with attenuated FAP. And the overall risk tends to be lower, more like 70% compared to that almost 100% that I had mentioned earlier with classic FAP. We also see considerably less adenomatous polyps, around 10 to 100, and often we don't see the additional cancer risks, so the thyroid and the liver cancer issues, for example. And again, most of the individuals with attenuated FAP have a mutation that's located in a specific area along the APC gene. Okay, so shifting gears a little bit, I'm going to now talk about a relatively newer syndrome that's very similar to attenuated FAP. It's called MUT-YH-associated polyposis, or MAP. And so from a polyposis standpoint, there are, again, often somewhere between around 10 to 100 polyps, but this can vary. And now we're actually identifying up to a third of cases where individuals have colorectal cancer without any polyps at all. So having polyposis in the name might be a misnomer. We're still learning about this condition, but in addition to adenomatous polyps, we're finding that there are hyperplastic polyps and serrated polyps. And finally, what makes this syndrome more unique is that it's inherited in what's called an autosomal recessive manner. So what that means is that in order for an individual to be affected, he or she has to inherit one copy of each gene from each parent. So if an individual inherits both, then they are affected. So there's essentially a 1 in 4 chance that this can happen. If an individual inherits just one copy, that person is considered to be a carrier, but not necessarily affected. So with this type of inheritance pattern, we tend to see more of a horizontal transmission. So what that means is we'll see maybe a bunch of siblings who have colorectal cancer, but no one in the generation above or a generation below. And the polyps and cancer risk are similar to those with attenuated FAP, but again, because this is a newer syndrome, some of these percentages and risks will get updated and change from year to year. And there's also some conflicting data as to whether or not these additional cancer risks are present outside of the GI tract. So one study looked at risks including ovarian cancer, bladder cancer, and skin cancer, and another study looked at the possibility of breast and uterine cancer. But we still don't know enough about these extraintestinal cancers to make screening recommendations about them yet. And to add to the confusion even more about this syndrome, there's a question as to whether or not those carriers, so those that have just one copy of a gene mutation in MUT-YH, if they might also have an increased risk for colon and breast cancer. And it's thought that around 1 to 2% of the general population are carriers of a MUT-YH gene mutation. So clearly we have much more to learn about the risks associated with this syndrome. And again, the screening for MAP includes colonoscopy at an earlier age and more frequently, every 1 to 2 years, and then upper endoscopy starting in the early 30s. And that frequency of screening might change depending on the number of polyps that are found in the colon. And then just like FAP, the benefits of NSAIDs to reduce polyps in individuals is being studied. So this table was put together by our very own Lisa Maxwell, and it's a very nice summary of the data that's looked at the number of polyps identified and then the chances of finding a mutation in either the APC or the MUT-YH genes. So as you can see, even with thousands of polyps, there's still only an 82% chance that we might find a mutation in one of these two genes. So clearly there are other risk factors, whether or not that's genetic, and lots of things that we haven't discovered yet. So these next two polyposis syndromes are even more rare, so I'm just going to introduce them briefly and give you an overview. But if you have more specific questions about them, I would recommend that you consider a personalized genetic consultation with a genetic counselor if possible. So P10 hamartoma tumor syndrome, or PHTS, is most often referred to as Cowden syndrome, and obviously it's associated with a gene called P10. There's a wide spectrum of polyp type, as you can see, but the most common are typically hamartomas, which are the benign growths that have more of a cancer predisposition than we previously thought. The cancers associated with Cowden syndrome include colorectal cancer at about a 9% risk, but you can see that there's actually a much higher risk for these other cancers, so breast, thyroid, uterine, and renal cancer. Cowden syndrome also has some very specific skin findings, and some of those are pictured here. There are papules and tricholomomas that we can see. These are sometimes what we refer to as the lumps and bumps on the skin or in the mouth. But the best way to determine if these are really the types of features that we would expect to see with Cowden syndrome is to get an evaluation by a dermatologist. And then one other feature that isn't pictured here that is one of the criteria for Cowden syndrome is having a large head circumference, so above the 97th percentile. So these are just some features that you might be able to look at and consider when you're evaluating your family history to see if there's any of these features. The screening recommendations for Cowden syndrome cater to the cancer risks, but again you can see on that fourth line that colonoscopy is recommended to begin at an earlier age, around age 35. So the next syndrome is called Peutz-Jeghers syndrome. This is an extremely rare condition, and once again hamartomas are the main polyp type. The hallmark feature involves skin findings too, which I'll show you in a minute. But the cancer spectrum is actually quite broad, including those in the GI tract, but also in the breast and other organs. The genes that are associated, the gene that is associated is called STK11. It also goes by another name of LKD1. And again, you can see that incidence is quite rare. So these are some of the skin findings that we can see with Peutz-Jeghers. You can see that there's a pigmentation around the mouth and on the face, and also on the hands and the feet. So again, having a dermatology evaluation is helpful for making a diagnosis of this syndrome as well. And then finally, there's juvenile polyposis syndrome, which involves a specific type of a hamartoma that are called juvenile polyps. These are diagnosed by a pathologist who knows what makes these different from the other types of hamartomas. And there's a lot of variety regarding the number of polyps identified in this syndrome, even within the same family. And there are two genes that are implicated in this condition called SMAD4 and BMPR1. And the cancer risks associated with juvenile polyposis seem to be restricted to the GI tract. So once again, screening involves upper and lower endoscopy, and that is pretty much all that we do for individuals with juvenile polyposis. So with that, I'm going to end my section talking about these more rare polyposis syndromes, and I'm going to hand it over to Lisa, who is going to speak about Lynch syndrome.
Thanks, Lisa. So getting started, I'm going to talk about Lynch syndrome, and as a first step, I think it's helpful to look at the incidence or estimated incidence of Lynch syndrome in the United States. So we believe that about 1 in 370 Americans has Lynch syndrome. This estimate is based on studies that looked at newly diagnosed colon cancers and found that about 2.8% of all newly diagnosed colon cancers are due to a mismatch repair mutation. And we believe that the penetrance of Lynch syndrome, meaning that of individuals who have a mismatch repair mutation, that they develop a cancer associated with it, is maybe up to about 50%. So taking these numbers and doing the calculation, it turns out that about 830,000 Americans have Lynch syndrome. We believe that about 10,000 of those individuals are aware of their diagnosis and are getting screening associated with that diagnosis of Lynch syndrome, but that only represents about 1.2% of all individuals. So we still have a lot of work to do in terms of identifying individuals who are at risk for Lynch syndrome and the cancers associated with it. So just thinking back in terms of how diagnosing individuals with Lynch syndrome has evolved, historically the Amsterdam criteria were the first criteria developed to identify individuals with Lynch syndrome. And those were the most stringent or strictest of criteria, and they involved having 3 relatives, all with colorectal cancer, in 2 or more generations, and one of those colon cancers being diagnosed before the age of 50. As we looked at more and more families that fell into this spectrum, we realized that there are really lots of other cancers associated with Lynch syndrome as well, like uterine cancer, ovarian cancer, gastric, hepatobiliary, small bowel, and some of the ureter. And we'll talk more about these in detail. So now we had the Amsterdam 2 criteria that allowed you to replace any one of those colon cancers with one of these other Lynch syndrome associated cancers. But we still recognize that there were a lot of individuals at risk for Lynch syndrome that were not being identified by these criteria. So the Bethesda guidelines were developed. These are not a diagnostic criteria, but they were a tool to identify which individuals might benefit from tumor testing to see if they might be at risk for Lynch syndrome. And then genetic testing has really been a huge player in terms of identifying individuals with Lynch syndrome, and also tumor testing. And this is what we would ideally recommend as the first step, either by microsatellite instability or immunohistochemistry, or a combination of the 2. And we believe that about 95% or so of Lynch syndrome-related colorectal cancers will be identified with that combination of microsatellite instability and immunohistochemistry. So just to review what those tumor screenings are, the immunohistochemistry is a staining test, and it stains for the presence of the mismatch repair proteins in the tumor cells. And so if the gene is functioning correctly, then the protein is made, and when we do the staining, we see that presence. But if there is absence of the protein, it means that there's something that is wrong with the gene. And that could either be an inherited mutation or change, what we call germline, or that might be a somatic or a random mutation that has happened over that individual's life that is now seen in the tumor but is not an inherited gene mutation. Microsatellite instability is a different type of test, and it uses PCR to look at 5 microsatellite markers to determine if a tumor is microsatellite high, which can be associated, can be a risk factor for Lynch syndrome, microsatellite low, which is more rare, or microsatellite stable, which is the most common finding in colon cancer. But it's important to remember that these tumor tests are really a screening test for Lynch syndrome. It is not diagnostic of Lynch syndrome, and there are certainly many individuals who have absent protein who may not have Lynch syndrome. So this is a busy graph, but essentially what the message it's trying to convey is that even if the protein is absent, only a portion of the time are we able to find an underlying germline mutation. And depending on which protein is absent, the likelihood to find a mutation may be will be different. So for example, if MSH2 and MSH6 are absent, about 2/3 of the time we're able to find an underlying genetic mutation. If only MSH6 is absent, only about 1/4 of the time will we find a germline mutation. And with PMS2 being absent, about half the time we find a mutation. And then with MLH1 and PMS2, only about 6% of the time is that absent. And that in the absent MLH1, PMS2, much of that is due to the hypermethylation that can occur in random colon cancers that causes that protein to be absent. So bottom line is that that tumor testing is not diagnostic for Lynch syndrome, but it is a clue to tell us to look at that individual or that family more closely, and that there may very well be other mechanisms that can cause that protein to be absent that are sporadic or random in nature. This is a case of an individual that I actually just called out these results to yesterday, and I'm going to show you another example of a family tree. So I'm just going to spend a minute orienting you to the family tree. So the yellow arrow is pointing at the gentleman that we met with. He is 58, and he had colon cancer diagnosed at the age of 57. The two women with, and so circles are women, and so the two women that are colored in are his sisters. And so right here, these are his parents, and then are his aunts and uncles on his mom's side of the family, his grandparents on his mom's side of the family, aunt and uncle on dad's side, and then grandparents on dad's side. So looking at this family history, he had colon cancer at 57, and then he has two sisters who both had young breast cancer, one at the age of 35, and she also has some colon polyps, and one at the age of 42. His maternal grandfather had some type of unknown cancer and died at 65. So this would not have been someone just based on family history that we would have thought had a high suspicion of having Lynch syndrome. But because universal tumor testing, if you're doing that, you're looking at every single colon cancer diagnosed, you may be finding individuals like this gentleman who had absent MSH6. And he was found to have an underlying germline mutation in his MSH6 gene. So this gives us new information for this family and potentially very important information for his siblings, aunts and uncles, and also his nieces and nephew. So universal screening or tumor testing can be a very helpful tool in identifying individuals with Lynch syndrome. So Lisa earlier mentioned the term genotype-phenotype, and so this is just when we know the specific gene, can we make predictions about in that individual that has that particular gene mutation, are there going to be differences in the types of cancer risks they may be at risk for? And so when we look at individuals with Lynch syndrome, MLH1 and MSH2 are by far the most common genes to have mutation in them in individuals who are found to have Lynch syndrome. And MLH1 is probably the most classic presentation of Lynch syndrome, and MSH2 as well, kind of the same types of colon cancer risks. In MSH2, we might see a little bit more of the extracolonic cancers like prostate and sebaceous skin neoplasms. But then MSH6 and PMS2 are ones where the risks of cancers may be less. And in the NCCN guidelines, for example, there are some slightly different screening recommendations for individuals who have a mutation in those particular genes. So when we think about Lynch syndrome and we think about the cancers involved, we all know about the colon cancer risk, and these numbers may be a little bit on the high side. So colon cancer risk, and second to that is certainly the endometrial cancer risk. Stomach cancer, biliary tract, the ovarian cancer risk, urinary tract, specifically the renal pelvis, ureter. We can also see some types of brain tumors in Lynch syndrome, for example, glioblastomas, and then those skin findings, sebaceous gland tumors or adenomas. But we're also learning some new information as we are finding more and more families who maybe didn't look like they had classic Lynch syndrome, but then by universal testing and genetic testing, we find that they do indeed have Lynch syndrome. And as we look at those families, we're finding that there is a probable risk for pancreatic, prostate, and breast cancer associated with Lynch syndrome as well. We don't include these cancers as part of the diagnostic Lynch syndrome associated cancers, but I think most of us in the field will say that certainly in thinking back to our Lynch syndrome families, that is not unusual for us to have seen individuals in the family with these types of cancers. So one of the challenges, though, is that the absolute risk of these cancers may not be that elevated, but we have certainly demonstrated that those cancers can be caused by mismatch repair mutations. So just to further clarify kind of what that means is that when we look at total risk, if we look at all Lynch syndrome families and we look at total risk for breast cancer, for example, does not seem to be significantly increased over individuals in the general population, but when we see young individuals in the family who may have had breast cancer and we test their tumors, some of those tumors do have loss of protein expression by immunohistochemistry, indicating that that breast cancer probably really was due to those underlying mismatch repair mutations. Because this information is still emerging and because the risks are not clearly defined at this point in time, we do not typically change medical management recommendations just based on finding a mismatch repair mutation for individuals that fall into this who have Lynch syndrome. But if these cancers are present in a family and there are potentially younger ages of diagnosis in a family, we may make some individualized recommendations for that particular family. So in individuals who work with Lynch syndrome or families at risk for Lynch syndrome know that there's a lot of different terms that are used out there in the literature. And I just thought it'd be helpful maybe to go over what some of those terms are and how they're used. So historically we used to, Lynch syndrome initially was called Lynch syndrome, and then there was a movement towards calling it HNPCC, or hereditary non-polyposis colorectal cancer. And I think today most of us in the field have really moved back to calling it Lynch syndrome. So today in the literature, hereditary non-polyposis refers to individuals who may fill Amsterdam 1 or 2 criteria. The term Lynch syndrome is reserved for individuals who have been found to have a germline mutation in one of the mismatch repair genes or in the EpCAM gene. Lynch-like is used to describe individuals who have had tumor testing. There was abnormality either by microsatellite instability or a protein was absent by immunohistochemistry. But when germline genetic testing or the blood genetic testing is done, no mutation is able to be found. So these are considered to be Lynch-like. Some of these individuals may truly have Lynch syndrome. Some of these individuals probably don't have Lynch syndrome and have a sporadic or random colon cancer. And then the last category are those that are referred to as having familial colorectal cancer type X. These are individuals or families that meet the Amsterdam 1 criteria. So there are 3 individuals in the family with colon cancer, but their tumor testing is normal. So there are probably other genes or mechanisms that cause this type of familial colon cancer clustering who we still don't have a genetic test to help explain why there is that clustering of colon cancer in those families. So this goes back to what I just mentioned, that about half of those individuals that are Lynch-like, which again is there's abnormal immunohistochemistry or microsatellite instability, but we can't find a germline mutation, nor is there MLH1 promoter methylation. They have a different somatic or random mutation in their tumor that is the cause of that tumor screening showing the absence of the protein or the microsatellite instability. I don't think we're quite here yet, but our technology is certainly emerging. Some centers are investigating doing more of the tumor genetic testing to help identify those individuals whose cancer is really due to a random or somatic mutation. And if that is found, they likely don't have Lynch syndrome and therefore may not be needing to do the Lynch syndrome associated screening. So this is probably something that we will see happening more and more across the country in the next few years. I would say that most centers, including ours, do not routinely do tumor genetic testing looking specifically at the mismatch repair genes at this point in time. And like Lisa mentioned, that we're identifying that some of the individuals who fall into this Lynch-like category do not have Lynch syndrome but have colon cancer due to biallelic MUT-YH mutations. So this segues into some of the discussion about next generation sequencing or panel genetic testing that we're going to be talking about now. So I was going to use a case to just describe approaches to genetic testing and how the results of genetic testing may translate into different medical management recommendations, and also to have that discussion about next generation sequencing testing. So here's a case of Annie. She is a 37-year-old unaffected woman who is in overall good health, but she does have a family history of cancer. She has a sister that was recently diagnosed with breast cancer at the age of 42. She has a paternal aunt, so her father's sister had ovarian cancer diagnosed at the age of 74. Her father had colon cancer at a younger age, and she had a paternal grandmother who also had colon cancer, but at a later age, at the age of 67. So here is Annie's family tree drawn up, and this is what we do for all individuals that we meet with. We draw up their family tree so that we can look for that pattern of cancer in the family. And the arrows always point to the individual who is the individual that we're meeting with for that cancer risk assessment in terms of discussing risk. So you can see Annie's sister there with her breast cancer, Annie's father with his colon cancer, and grandmother with colon cancer, and then Annie's aunt with ovarian cancer at 74. So in meeting with Annie, a physician might ask, has there been any genetic testing done in her family? And Annie's response to this was that, yes, indeed, her sister did have a genetic test done. Like Lisa mentioned earlier, I don't think we can emphasize enough how important it is to get a copy of these genetic results, especially in the light of how much more genetic testing is being done, how many different labs offer genetic testing, how many different genetic tests there are out there, and also that there are so many different modalities in terms of what type of genetic testing was done. So today we have direct-to-consumer genetic testing, we have tumor-based genetic testing, and then we have germline genetic testing. And really based on what genetic test was done, it can give us very different information for Annie and for her family, and really dictate what our next step would be. The biggest change for us in the world of genetics and cancer genetics is what we call next generation sequencing. And as this slide implies, we can now do testing, so it's buy one, get a dozen free. We can now do genetic testing looking at lots of genes for what we just a couple of years ago would have been looking at only, in terms of cost, would have been looking at only 1 or 2 genes. So our old type of genetic testing was called Sanger sequencing, and it tended to be much more cumbersome and much more expensive. With the advent of next generation sequencing genetic testing, the cost of genetic testing has gone down dramatically, and our ability to look at lots of different genes all at the same time is really new technology, and has really led to a new approach to genetic testing and to evaluating families that we're meeting with. Like I just mentioned, there are lots of labs out there that now offer panels for genetic testing, and the different panels may have different genes included on them and may have a different number of genes included on them. I've included on this slide just a couple of different panels that we use pretty regularly. The MyRisk panel, which is offered by Myriad Genetic Labs, which looks at about 25 genes that convey an increased risk for many different types of cancers. So they include genes, pretty much all, not all, but the main players that have been described as causing cancer risk, not specific to colon cancer, but so on this panel they include genes that convey an increased risk for breast cancer, ovarian cancer, uterine cancer, colon cancer. So it's really casting the net wide, and I think it is going to change a lot of what we understand about the cancer risks in some of these families. I think in many ways in the genetic world, in some ways we were a self-fulfilling prophecy. If a family looked like it had Lynch syndrome, we would test for the genes associated with Lynch syndrome. If a family looked like it had hereditary breast and ovarian cancer or mutations in BRCA1 and 2, we would test for BRCA1 and 2. So now with the advent of these panel tests, we may be finding families that don't look like what we would have classically expected based on the literature. So some of these genes that are included on these panels, and pretty much most of these panels include these well-described genes, are ones that can cause an increased risk for some of those polyposis syndromes that Lisa spoke about. Some of these other genes that are included on the panels are ones that typically don't involve an increased risk of polyps, but we know, those are the Lynch syndrome associated genes, but there are also some new genes that are also described as potentially causing an increased risk for colon cancer. I'm not going to spend a lot of time talking about the specifics of the panels, but just something to be aware of, that a lot of these panels have some relatively newly described genes on them for which we don't understand the absolute cancer risks, and we don't have clear-cut medical management guidelines. So when we do this panel testing, that is one of the limitations or risks associated with it, is that we may get information for which we don't have all the answers at this point in time. So there's certainly a lot of information that still needs to be gathered about some of the other genes that are described on some of these panels. So one of the times that we typically think about doing next-generation sequencing for colon cancer, we still here at the University of Colorado do universal tumor screening on all newly diagnosed colon cancers and newly diagnosed uterine cancers. But there are times when we may not have that information. For example, someone may be coming in and meeting with us for a second opinion. We may not be able to access that tumor tissue. And in that setting, a next-generation sequencing panel can be a very good option. Also for young individuals who maybe have had tumor testing, but the tumor testing was normal, doing a panel that might include some of these other genes that have been described as causing an increased risk for colon cancer, like the MUH gene, TP53, and CHEK2. And then if individuals report multiple polyps, but we're not able to get those pathology reports, we don't know specifically were they adenomas, were they hamartomas, or if they, for example, describe lots of polyps in a family member, doing a panel that allows us to look at all the polyposis-associated genes is often a very good approach. And I'd say the most common scenario where we do next-generation sequencing testing is that there are lots of different types of cancers in the family. So we're potentially thinking about multiple different types of syndromes that could possibly explain the cancers in the family. And this certainly is the case for Annie's family. So if you recall, there's breast cancer in the family, ovarian cancer in the family, and colon cancer. And so we know the most common explanation for breast and ovarian cancer is the hereditary breast and ovarian cancer syndrome due to mutations in BRCA1 and 2. But we know that we can sometimes see breast cancer with Lynch syndrome, and that certainly ovarian cancer and young colon cancer are commonly seen in Lynch syndrome. So here we did one of those broader tests, and we found that Annie's sister did have a mutation in her MSH2 gene, which is one of the Lynch syndrome associated genes. This now allows us to really give specific medical management recommendations for Annie's sister. We would recommend genetic testing for Annie, and it would potentially change medical management for family members. So what do we know about medical management in Lynch syndrome, and specifically focusing on the colon cancer risk as a first step? And we know that that cancer happens younger, and that there's a more proximal location, and that individuals are at a higher risk both for developing synchronous, or cancers that occur at the same time, or metachronous, meaning that they have one primary colon cancer and then develop a second primary colon cancer at a later point in time. We also know that in Lynch syndrome, the progression of colon cancer from polyp to cancer is faster than it is in the general population. So in the general population, we believe that it takes about 8 to 10 years from the time of normal epithelium to the point of a colon cancer, whereas in Lynch syndrome that is much faster, somewhere between 12 to 36 months. So we know that doing more frequent colonoscopies is more important in Lynch syndrome, and that we get a good look at that right-sided colon as well. So here are the NCCN guidelines for Lynch syndrome. I'm not going to go through them all in detail, but you all have them here as a reference. But certainly colonoscopy, starting that at an earlier age. The NCCN has recently added that aspirin may potentially decrease risk of colon cancer in Lynch syndrome. There are still ongoing studies now trying to determine the exact dosage that would be recommended in this setting. And like I mentioned earlier, MSH6 and PMS2 carriers should consider starting this a bit later. But I would say for any family that has Lynch syndrome, it's always important to take a close look at that individual family because there may be younger colon cancers. For example, I know we have a number of families with PMS2 mutations where there are quite young colon cancers, and so for them, those families, we've made individualized screening recommendations that involve starting colonoscopy earlier than maybe what the guidelines recommend. Certainly, the endometrial and ovarian screening, we had that discussion, and then we also have this discussion about potential preventive surgery with a hysterectomy and removing the ovaries as a risk-reducing option for women who've completed their families. And certainly any woman with Lynch syndrome needs to know if there is any type of abnormal uterine bleeding, that should trigger a close discussion with her doctor and evaluation. And the guidelines have changed somewhat in terms of the stomach and small bowel screening. And those families where there has been a history of stomach or small bowel cancer, they might have an individualized recommendation to do that small bowel screening. And also the NCCN guidelines mention those of Asian descent may consider that upper endoscopy screening. And then urine analysis. And then other screening to potentially consider would be annual physical exam with a neurologic exam. And there's still, I think, in the next little while, there'll probably be some clarification whether or not breast and pancreatic screening is recommended. Currently, that is based on the specific family and family history of those cancers. But I think another important consideration is that a lot of the time, a family like Annie's, so here we have Annie's family again. It is pretty frequent that we do genetic testing and we don't find a genetic change or mutation. So again, if it had been Annie's sister that had genetic testing and she did one of those broad next generation sequencing panels and we did not find a genetic change, we would still say that this family has an increased risk of cancer based on the family history. So it is important to know that a negative genetic test, if we have not identified a mutation in the family, is considered uninformative, and we would still manage the family based on the family history of cancer. Or, for example, if that negative result had instead been Annie's, say no one in the family had genetic testing, Annie chose to have genetic testing and we did not find a mutation. In that setting, she's still at increased risk. We would still make an individualized medical management plan for her. We would do more frequent colonoscopies. We would start them younger based on the family history. She would, in all likelihood, be considered at high risk for breast screening in terms of annual MRIs, and she may consider tamoxifen as she gets older for prevention as well. And due to the ovarian cancer in the family, she might be recommended to discuss whether ovarian screening would be appropriate for her. So what we do in our hereditary cancer clinic, our job is to really analyze these family histories. So look at it in detail, talk about what those cancer risks are based on the family history, whether genetic testing can be a useful tool potentially to help explain why the cancers are occurring in the family, and then to help determine those guidelines for medical management in terms of family history and ages of diagnosis and types of cancers in the family. And we also talk about genetic information is family information, and that can often bring up some complicated family dynamics in terms of sharing results, whether or not family members have a mutation and versus others who don't. So we spend a considerable amount of time discussing those issues with our families as well. And then we help coordinate and order genetic test results, and at times help individuals or families participate in research studies if they're interested, and we can find ones that they may be eligible for. So I think our take-home message with this presentation is to talk to your doctor about your family history of cancer and your risk factors for cancer, and so that you can have your own individualized cancer screening recommendations based on your family history, whether that be those of the general population or whether there are enough cancers or young enough cancers in the family that an individualized approach is really the more appropriate screening recommendation, or if you're identified as having a genetic mutation or change, in which case there's very specific guidelines and ages of screening and so forth to consider. So we've included some websites that are excellent resources for individuals who may be at risk for inherited colon cancers. And I'm going to stop here and just see if there are any questions that have come up during Lisa's and my presentation and discussion.
Thank you so much to both of you, Lisa and Leeson. I think this presentation was wonderful, and we've had a lot of really great questions come in, so I can start delving into those if you all are ready.
Okay.
All right. So we did have a question, and it is specific about two types of syndromes, but are there any evolving overall typologies, or is there any fluidity between Gardner syndrome and PJS?
So Gardner syndrome is considered a subtype of familial adenomatous polyposis. I don't know if there's been any link between calling Gardner syndrome and juvenile polyps, but it's typically basically the extra colonic manifestations that we see with familial polyposis. Those are what are more well defined for Gardner syndrome.
And I would just add, if someone feels that they have those extra colonic features that we see in FAP and they have a history of colon polyps, maybe having a second opinion from a pathology standpoint to double check, are those colon polyps really juvenile polyps, or could they indeed be adenomas, and that it really all fits more into the FAP or Gardner syndrome.
Thank you. So another question is about if you know of any new research or treatments with APC mutation in Ashkenazi Jewish populations?
Not that I'm aware of. There's one particular mutation, the I1307K, that is more commonly described in individuals who have Ashkenazi Jewish ancestry. This particular mutation does not cause classic FAP and may convey a slight increase in colon risk, but so even though it's a mutation in the APC gene, it does not translate into familial adenomatous polyposis.
Okay. So in Lynch syndrome, is it specifically colon, or is rectal cancer included in that as well?
It's referred to as colorectal. By far, the 2/3 of the time, the cancers we see in the colorectum are those right-sided colonic polyps. So rectal cancer is we don't exclude it in Lynch syndrome, but it's certainly more rare.
Okay. And then also, we have a lot of questions regarding Lynch syndrome, and I know that you went over some of the guidelines, and that just to clarify, so for Lynch syndrome, when should mammograms begin, and what is the breast cancer risk associated with it, and any information on insurance coverage for those earlier testing?
So guidelines say that mammograms should start at 40 for breast cancer screening in Lynch syndrome. No MRIs, no high-risk screening. But if someone has a family like one of those that I presented where they have a family history of breast cancer, they may be recommended for breast cancer screening based on their family history. So there are no Lynch syndrome guidelines for increased or earlier screening for breast cancer. So unless there's a family history of young breast cancer, I would not expect insurance would cover MRIs or earlier screening. So that is going to be unique to families, whether or not increased breast cancer screening is recommended and when it would start.
Okay. And then as far as, the younger onset of colorectal cancer being on the rise, do you think Lynch syndrome is behind this increase?
I don't think so, but I think there are a lot of questions we still have to answer. What we understand, having done that systematic screening of all colon cancers diagnosed, it gives us a pretty good picture of the incidence of Lynch syndrome and the frequency of Lynch syndrome. And we don't expect that Lynch syndrome has increased or changed, but are some of the lifestyle things that Lisa mentioned, they in all likelihood impact the general population as well as families or individuals who might have Lynch syndrome. I think those are hard questions to answer, the environmental questions, and
what they're also starting to find is that there seems to be an increased risk in that population between age 40 and 50, and so some of the studies are looking to see whether or not increased screening within that population may be beneficial, but I don't think that the evidence is there yet to actually say that we can include that yet.
Okay. So more generally with genetic testing and selecting panels for genetic testing, how should you select a panel for genetic testing, or what information should you know on how to advocate for a certain panel to be completed?
I think it's a challenging question. I think checking in with the patient, determining their level of comfort with a lot of these less well understood genes, their level of comfort with, we may find something that we don't quite yet know what it means for you in terms of cancer risk, what it means for your family in terms of cancer risk, is important so that the patient is making an informed decision about their genetic test. And I think one of the important things to know is about 40% of the time when we do one of these broad genetic tests, we find what we call a variant of uncertain significance. It means we found a change in the genetic code, but we don't know what it is at this point in time. It could be normal variation that has nothing to do with cancer risk, or it could indeed convey an increased risk for cancer. And so those are just some of the risks to discuss with individuals considering doing one of these larger panels, that they are new. They potentially give us more information, but some of that information is still so recent, still so new, that it may not be concrete. And in terms of deciding which one to do, it kind of depends on the patient. Are they someone who is an information seeker and are comfortable with just that it may be a bit of a fishing expedition, that we may be casting the net wide and finding something that we don't quite know? Or are they more comfortable focusing on the genes that we understand well and can give clear medical management recommendations to them and their family?
I think we spend a great deal of time when we're doing genetic counseling on that aspect now. Because of the advent of next-generation sequencing, we spend a lot of time talking about what those options are. But two individuals who have the same exact family history will have a very different approach to how much or how little information they want to know. And I think, oftentimes the message that the message that we're presenting is that we want to make sure that that information from a genetic test is going to be used in a positive manner. So in other words, knowing this information might change medical management or change how you might approach some decision making versus being a psychological burden, because we don't want that to be the case. As Leeson said, there are lots of individuals who don't deal well with information that's sort of where we're unsure of what to do with that information. And with all of those variants of uncertain significance, we often have that issue.
Okay. That's very helpful. I think we have a lot of specific questions on a few syndromes, and I'm not sure to what detail you all will be able to cover this, but there were some questions that came up about APC mutations on Lynch syndrome. Is there anything that you could add related to that?
So APC mutations cause familial adenomatous polyposis. It doesn't cause Lynch syndrome. So I would need to know more specifics about what the question specifically was.
I think just more information on APC mutations, and is it due to hereditary concerns with all Lynch, or I guess that relationship?
So I think this may be getting towards, so more and more individuals are having tumor testing, and APC is a very common gene to be mutated in random sporadic colon cancers. And, but that is APC mutations, the germline inherited ones, don't cause Lynch syndrome. They cause either attenuated familial adenomatous polyposis or the classic familial adenomatous polyposis.
Okay. And do you all know any information on BHD, and I'm not sure if I'm going to pronounce this correctly, but it's Birt-Hogg-Dubé syndrome?
Birt-Hogg-Dubé.
Okay.
And so Birt-Hogg-Dubé is an entirely different syndrome that is typically characterized by sporadic pneumothorax. So you can have lung cysts, you can have kidney cysts. The primary cancer risk in Birt-Hogg-Dubé is actually kidney cancer. I don't know there to be a significant increased risk in colon cancer.
It might be an association, but
yeah, not specific screening typically for colon cancer in Birt-Hogg-Dubé.
I think we would really welcome those types of questions to be asked more specifically to that individual's genetic counselor, whoever, whatever provider maybe provided that information to get a little bit more of a specific education.
Okay. And we've had some questions come in about if you have a certain mutation, what are the implications for your family members? Do you have any tips on how to get your family to the doctor and receive genetic testing, or what should that conversation look like with your family members?
So I think most families are unique. A lot of genetic counselors will share a family letter with individuals who maybe don't have a relationship where they feel like they would just call and share that information with family members. For example, if it's cousins and aunts and uncles, then maybe they haven't talked to in many years. And so sometimes that's an easier way to facilitate sharing that information. And essentially what those letters typically say is just, I've had genetic testing, and this may be information that may be helpful to you or your provider to discuss. I would refer individuals who are looking for resources for their family members to the National Society of Genetic Counselors website. It is nsgc.org, and on there's the ability to search by region and by specialty for genetic counselors. The most important piece of information to share with family members is an actual copy of the genetic test results. So pretty much all labs today will request, if a family member has been found to have a mutation and you want to do testing for that specific mutation, pretty much all labs will request a specific copy of that family member's genetic test result. So that's the most important piece of information to share with family members. So a family letter and potentially the specific genetic test results. You want to add anything?
I think we've had some good success with that, and with the advent of social media now, a lot of individuals have been able to find their family members through things like Facebook or being able to email, which is a little bit less of a, having to make a phone call or whatnot, so sharing that information more passively.
Yeah. And again, just to emphasize, I think we've all experienced individuals who've called and said family members have been found to have a mutation, or I have Lynch syndrome, or I have a family member has Lynch syndrome. And then when we get the actual test results, we might see something different. So having that test result in hand is hugely
Absolutely important.
Yeah.
And as far as getting your family members screened, and we've covered this a little bit, but what can you tell us a little bit more about insurance coverages for your family members? What experiences have you had with that?
In terms of genetic testing, you mean, or? So each insurance company is different, and they have their own set guidelines. Most of them are now following pretty closely to the national guidelines. So if there's a known mutation in the family, almost always that's going to be covered unless there's a specific genetic testing exclusion in the plan, or if they have Medicare, which Medicare requires that the individual being tested has to have an actual diagnosis of cancer, and specifically for Lynch syndrome with colon or uterine cancer. But most of the insurance companies are really pretty good about covering a known mutation. For if it's the first person in a family being tested, then again there are usually specific criteria that need to be met, and so that has to be looked at for that specific plan.
Is that something that a genetic counselor is able to point, to help with that?
Yes, we do. We do spend some time doing that. The other thing is that many of the labs are going towards actually helping with doing that process as well. So they have individuals on their staff that will actually do either a pre-authorization of some sort with the insurance, and they wait to get that information before they process the test. So there's sort of help on both sides with that.
Wonderful. Let me check and see if there's any more questions that have come in. I don't see any at this time. If we weren't able to get to your questions that were very specific, I'll try to follow up with some individuals about specific questions that we may be able to address with some additional resources that we have. But it looks like Lisa and Lisa, those are all the questions that I have from the audience. So I just want to thank you all both so much for holding this follow-up webinar. I think it's super helpful for all of our, all the patients and family members and anyone interested in genetic information. So I want to remind everyone that we will be having our next webinar on Tuesday, February 17th at 1:30, and that's Eastern Time, and that'll discuss emerging research with colorectal cancer, what we learned at the GI ASCO Symposium, as well as how to get involved as a research advocate. So that will be our next webinar. Be on the lookout on Facebook and on our website for more information about that. So thank you again, Lisa and Lisa. We really appreciate all of your information.
Thank you.
Thank you.
Hey, Michael, I think that
Still there, Gabby?
yeah, I'm still here.
Yeah, I'm going to get out of the session.